Welcome everyone to Cardiology 305. I'm Dr. Fernandez, and today we're unlocking one of the coolest, most underappreciated intersections in medicine: autoimmune and inflammatory cardiodermatology disorders. Your patient's skin isn't just covering it, it's a screening billboard or what's happening inside their heart. This lecture is for educational purpose only, but the knowledge you're about to get, pure gold for boards, awards, and real life saves. If you're watching on YouTube, smash that like button right now and subscribe because these skin clues can literally be life saving. Let's dive in. Cardiodermatology. Picture this: the skin and the heart are like two best friends who went to the same party and both got wrecked by the same disease. Cardiodermatology is that wild interface: autoimmune, infectious, genetic, infiltrative, metabolic, iatrogenic, hemodynamics, you name it. Connective tissue disease are the MVPs here because the exact same immune attack that torches the skin also torches the heart. Keep this in mind. When you see certain rashes, your brain should immediately ping cardiac workup. This isn't trivia. This is how you catch silent killers early. Systemic lupus erythematosus, SLE. A classic lupus, the poster child. That butterfly mala rash, discoid lesions, photosensitivity, those aren't just dermatological problems. Inside the heart, you're looking at pericarditis, myocarditis, Liebman sac endocarditis, those sterile vegetations that love to embolize, and turbocharged atherosclerosis. Young women with lupus are basically running cardiovascular risk that looks like someone twice their age. Next time you see a malar rash, don't just treat the skin, order the echo and lipid panels. Your patient will thank you. Systemic sclerosis, or Scleroderma, is sneaky and brutal. Raynaud's sclerodactyly, digital ulcers, telangiectasias on the face. Patients look like they're slowly turning to stone, but the heart, myocardial fibrosis, dangerous arrhythmia, and pulmonary arterial hypertension, that is the number one killer. Pulmonary arterial hypertension (PAH) is in this patient is like a silent time bomb. When you see tight shiny skin and cold purple fingers, your cardiology radar should be blaring. Early right heart cath can be the difference between life and a very short lifespan. Dermatomyositis. Gotron's papules over the knuckles and that violaceous heliotrope rash around the eyes. Pathognomonic, beautiful, and terrifying. What most people miss: up to 50% of these patients have subclinical cardiac involvement that only advanced imaging picks up. So, while dermatology is busy treating the rash, the heart can be quietly inflaming. A pro tip: every dermatomyositis patient gets cardiac MRI or echo with strain imaging. Don't wait for symptoms. The heart doesn't always shout before it fails. Rheumatoid arthritis. Rheumatoid nodules and vasculitic ulcers on the skin, classic. Inside the chest, pericarditis, an accelerated coronary artery disease that can make a 40-year-old look like a 70-year-old on the cath table. RA is systemic fire, and the heart is one of its favorite targets. If your RA patient has nodules, assume their coronaries are under attack too. Statins, anti-rheumatic control, aren't optional, they're mandatory. Mixed connective tissue disease, MCTD, is the ultimate overlap party. Features of lupus, scleroderma, and polymyositis, all in one patient, glued together by high titer anti-U1RNP antibodies. The skin looks like a mix and match of the others, and the heart can show pericarditis or pulmonary hypertension. Variable, unpredictable, but deadly if you miss it. Think of MCTD as the choose your own adventure of autoimmune disease. As said, the bad ending is heart failure. High suspicion equals early screening. Cardiovascular risk in autoimmune disease. Here's the jaw dropper. A massive UK study of 22 million people showed that SLE and systemic sclerosis carry the highest cardiovascular risk of any autoimmune disease. We're talking myocardial infarction, stroke, heart failure, and cardiovascular death, all accelerated. These aren't just comorbidities, they are the main event. Every rheumatology or dermatology visit should include a cardiovascular risk calculator update. This data change guidelines, and it should change how you practice tomorrow. Vasculitis, an overview. Vasculitides are the vessel's terrorists of medicine, classified by size: large, medium, small, and variable. They don't just inflame vessels, they wreck skin and heart in a spectacular fashion. Today, we're hitting the biggest cardiac players. Remember, vessel size on the slide equals the size of the disaster inside the patient. Let's meet the culprits. Giant cell arteritis and Takayasu arteritis. Giant cell arteritis and Takayasu, the large vessel villains. Aortic aneurysm, dissection, aortic regurgitation, all possible. Scalp tenderness. In giant cell arteritis, erythema nodosum in Takayasu, treatment, high dose prednisone, 40 to 60 milligrams per day, like your patient life depends on it, because it does. Tocilizumab is now the steroid-sparing superstar for GCA. Catch this early, or the aorta can literally explode. This is why jaw claudication and new headache in anyone over 50 is an emergency. ANCA-associated vasculitis. EGPA, eosinophilic granulomatosis with polyangiitis, takes the prize for highest cardiac risk among small vessel vasculitis. Palpable purpura, ulcers, nodules on the skin. Inside the heart, eosinophilic myocarditis that can destroy pump functions fast. This one is sneaky. Patients can look like they have bad asthma until the heart suddenly fails. Eosinophilia plus purpura equals immediate cardiac workup. Don't sleep on this. Polyarteritis nodosa, PAN. Polyarteritis nodosa loves medium-sized arteries, including the coronaries. Livedo reticularis, subcutaneous nodules, digital ischemia on the skin. Heart attacks from coronary vasculitis? Absolutely. This is one where the skin literally maps the vascular battlefields. Classic board question. Livedo plus nodules plus abdominal pain is equal PAN until proven otherwise. Treat aggressively or the heart pays the price. Behçet's disease. Behçet's, the variable vessel wildcard. Painful oral and genital ulcers outside, intracardiac thrombi, and endomyocardial fibrosis inside. It is like the body is throwing clots and scar tissues everywhere. Young patients with recurrent mouth ulcers and new heart symptoms think Behçet until proven otherwise. This disease doesn't play by the rules, and neither should you diagnose approach. Sarcoidosis, an overview. The great mimicker, granulomas everywhere. The screen shows erythema nodosum, lupus pernio, or random papules that looks like anything else. Well, but when those granulomas hit the heart, game over if you miss it. This is where every sarcoidosis diagnosis should trigger cardiology consult. The skin is giving you clues. Listen to it. Clinical features of cardiac sarcoidosis. High grade AV block in up to 42% of cases. That's insane. ventricular arrhythmias that can cause sudden death plus heart failure. Cardiac sarcoid doesn't always scream, sometimes it's whisper until the patient collapses. This is why we screen every new sarcoidosis patient. The heart involvement can be silent until it's catastrophic. Screening and diagnosis of cardiac sarcoidosis. The American Heart Association says screen them all. History, physical to leaf EKG. If anything is off, straight to cardiac MRI for inflammation and fibrosis. Or FDG PET CT. This protocol catches disease before the defibrillator is needed. It's simple, it's effective, and it saves life. You can do it. Management and prognosis. Prednisone 30 to 40 milligrams daily, first line. Methotrexate for steroid sparing, ICD for high-risk arrhythmias. With proper management, 5-year survival jumps to 90 to 96%. That's a massive win. Early diagnosis turns a deadly disease into a manageable one. This is why screening matters. You can literally rewrite the prognosis. Antiphospholipid syndrome, APS, livedo reticularis, skin ulcers, digital gangrene on the outside, inside, Liebman sac endocarditis, coronary disease, intracardiac thrombi. Diagnosed needs persistent antibody 12 weeks apart, plus clotting or pregnancy issues. This syndrome loves to thrombose everything. Think of it as the body's own hypercoagulable nightmare. Management. Lifelong warfarin with INR 2 to 3 still skin. DOACs are generally not recommended in high-risk patients. The data is clear. Get the antibodies right, anticoagulate right, and you prevent strokes, heart attacks, and valve destruction. This is one protocol you do not want to get wrong. Inflammatory dermatosis, psoriasis, moderate to severe psoriasis, 50% increased risk for myocardial infarction. The mechanism, TH and TH17 inflammation-driven endothelial dysfunction, and atherosclerosis on steroids. ACC and AHA and dermatology guidelines now call psoriasis a risk enhancer. That plaque on the elbow isn't just cosmetic, it's a cardiovascular red flag. Treat the skin and the heart risks. Hidradenitis suppurativa, HS, is brutal, 57% higher MI risk, 33 higher stroke, 95 higher cardiovascular death. And the newest data shows shared genetic loci with coronary disease and diabetes. Painful balls in the armpits and groins are literally linked to heart attacks. This is why hidradenitis suppurativa patients need aggressive cardiovascular risk modification. Skin disease this severe is never just dermatology. Infective endocarditis, ulcer nodules, tender red nodules on finger pads, Jane Wade's lesions, painless hemorrhagic spots on palms and sole, a splinter hemorrhage, petechia, purpura. A huge French study showed these skin findings means bigger vegetations and more cerebral emboli. Your patient hands and feet are giving you a prognosis preview. See the skin signs, think bigger, emboli risk, and act fast. Embolic syndrome, cholesterol embolization after a cath or vascular procedure, suddenly livedo reticularis and blue toe syndrome, eosinophilia and renal failure seals the deal. Management is supported. Statin, antiplatelets, no anticoagulation. This is the body showering itself with cholesterol crystal. Painful, ugly, and preventable if you're careful with procedures. Embolic syndrome, atrial Here's the viral story. A weird acral rash, Erythematosus papules, livedo maculis, petechia, and its actual tumor emboli from an atrial 17 cases reviewed, 41% went to have stroke. The rash is the sentinel that screams, "Echo me now." Surgical resection cures it. Next time you see an unexplained distal rash, grab the echo probe. This one saves lives. Genetic, Nasus disease and Carvajal syndrome, woolly hair and palmoplantar keratoderma from birth. Innocent looking, right? Wrong. Desmosomal mutations, GUP and DSP, and the heart develops arrhythmogenic cardiomyopathy with sudden death risk. That 80.1 cardiac disease risk when both skin and hair are involved. That's a mandatory lifelong cardiac monitoring situation. The skin and hair are waving the red flag from day one. Genetic rasopathies, Noonan's, cardiofasciocutaneous, Costello syndrome, lentiginous cafe au lait spots, ichthyosis, papilloma on the skin and inside, pulmonary stenosis or hypertrophic cardiomyopathy. These kids have congenital heart defects plus skin findings that scream genetic syndrome. Early echo and genetic consult changes everything. Anderson-Farris disease, angiokeratoma, corporis, diffusion, those classic red-purple spots on the bathing suit distribution. X-linked lysosomal storage disease causing progressive left ventricular hypertrophy. Enzyme replacement therapy started early literally slows the cardiomyopathy. Classic bore peril, young men with LVH and angiokeratomas equals Fabry's until proven otherwise. Treat early, saves the heart. Vascular Ehlers-Danlos syndrome, thin, translucent skin, visible veins, easy bruising, acrogyria. Patients look fragile because they are. COL3A1 mutations make arteries explode, dissection, aneurysm, rupture. Median survival 48 to 50 years if untreated. This is one where the skin is a warning level for catastrophic vascular events. Management guidelines 2022 ACC/AHA guidelines, baseline MRI or CTA from the head to pelvis, annual surveillance avoids invasive procedures like the plague. Consider celiprolol. Invasive angiography, absolutely. Contraindicated, it can kill them. This protocol is non-negotiable. Get the imaging right and you can extend life dramatically. Infiltrative amyloidosis, AL amyloidosis, raccoon eyes, periorbital purpura, and macroglossia. Heart shows restrictive cardiomyopathy with concentric LV thickening. Red flags, heart failure with preserved air with low voltage ECG and carpal tunnel. Technetium PYP scan light up ATTR like a Christmas tree. The skin is giving you the diagnosis before the heart fully fails. The therapy for amyloidosis. ATTR gets tafamidis, disease modifying and game changing. AL needs plasma cell therapy. Multidisciplinary centers are key. Catch it with the raccoon eyes or carpal tunnel, and you can actually treat the underlying cause instead of just diuresing forever. Metabolic carcinoma syndrome, episodic flushing, persistent cyanosis, telangiectasias, pellagra like dermatitis, and over 50% develop right-sided valvular fibrosis. Urinary 5 HIAA and NT-proBNP greater than 60 are your screening tools. The skin changes are the visible tips of the neuroendocrine iceberg. With the management, somatostatin analogs, octreotide LR 30 milligrams or lariotide 120 milligrams first line, telostristat for diarrhea, valve surgery for severe heart disease. Multidisciplinary magic turns a miserable syndrome into something manageable. The flushing isn't just embarrassing, it's a cardiac warning. Metabolic calciphylaxis. Violaceous painful plaques turning into necrotic ulcers in dialysis patients. Incidence 0.04 to 4%. 1 year mortality over 50%. Pain is described as worse than childbirth or burns. This is arteriolar calcifications and thrombosis at its most vicious. The skin tells you the patient is in a fight for their lives. Calciphylaxis management, fix calcium and phosphate, stop warfarin and calcium binders. Sodium thiosulfate 21 grams IV 3 times a week post-dialysis, aggressive wound care, and pain control that usually needs multimodal opioids. This takes a village: nephrology, dermatology, wound care, pain team. Early intervention is the only hope. Iatrogenic cardiac medications adverse reaction. Amiodarone turns patients slate gray and phototoxic in up to 75% on long-term therapy. Warfarin skin necrosis in the first week. Painful plaques to bulle to necrosis. Diuretics and calcium channel blockers spike eczematous dermatitis in older adults. Every med we give can bite back on the skin. Know the patterns. Hemodynamics, heart failure, cutaneous signs, pitting edema, stasis dermatitis with bron hemosiderin, acrocyanosis, skin breakdown. Heart failure patients have zero lymphatic reserve. The Happify trial proved it. That leg swelling isn't just edema, it's the heart failing to pump and the skin paying the price. Diuresis plus compression, if arteries are okay, prevents ulcers. Cardiac devices complications, pocket erythema erosions with device poking through hematoma keloids and full-blown device endocarditis. LVAD driveline infections are the most common skin nightmares. HS says infect device pull the whole thing and leads. Antibiotics alone almost never work. These complications are rising with more devices. Know them cope. Diagnosis framework: clinical eyes plus serologist plus echo with strain plus cardiac MRI plus PET CT plus skin biopsies with immunofluorescent. The tool assists. Use them together. Speckle tracking catches the subclinical disease in lupus and scleroderma. This multimodal approach is how you stop guessing and start knowing. Multidisciplinary management: rheumatology, dermatology, cardiology, nephrology, genetics, all in the same room. Chronic inflammatory skin disease are now official ACC/AHA risk enhancers. Genetic counseling for NASOs, rastopathies. Tailor immunosuppression, but watch for steroid-induced hypertension and lipids. Teamwork makes the dream work and keeps patient alive. Early recognition is a life-saving dermatological harbingers. Woolly hair, possible sudden cardiac death, raccoon eyes, amyloid, acra rash, myxoma emboli. These skin signs are the canary of the coal mine. Spot them, echo them, save them. This is the entire point of cardiodermatology. The skin is talking. Are you listening? Every single fact today is backed by the reference listed from the huge UK population study. These aren't opinions, they are evidence. Save the slides, cite them on rounds, and look like the rock stars you are. Thank you. And questions. That's it. You know have a superpower, seeing the heart through the skin. If this lecture makes you look at the next patient differently, drop a comment below with your favorite skin heart peril. Share this with every med student, resident, and colleagues you know, because these clues save lives. Thank you so much for watching. Questions? Far away in the comments. I'm Dr. Fernandez. Stay curious, stay sharp, and keep looking at the skin. See you in the next